Welcome everyone to the final webinar in our series on perspectives on cost effectiveness thresholds in the United States. I'm Rick Chapman, Director of Health Economics for ICER. Today we'll be hearing a recap and summary from Steve Pearson, the founder and president of ICER. And after his discussion, we'll have a couple of invited respondents. We've got Patricia Danzen and Carl Kletzman responding today. And hopefully we'll have some time at the end for questions and further discussion. And now I'll turn it over to Steve Pearson.
Thank you, Rick, and hi, everybody. And actually, this is the last of our webinars. It's been a wonderful experience for us at ICER, and we look forward through these recordings to being able to share this with obviously not just those listening today, but with a broader set of folks. I do want to be careful to clarify that this is not intended to be a summation or a summary of everything that's come before. This is not my attempt to wrap it all up and put a bow on it and say, you know, exactly what's the right answer, because again, that wasn't the goal of these webinars. They have been a wonderful opportunity for us to think deeply, to take a step back and to hear from some of the very best thinkers on some of these issues. And what I'm going to do is to focus a little bit more on some of the ethical aspects that I think may have a role in thinking through some of the pros and cons of different approaches to a threshold. Now, first of all, I am not a health economist. And so I have to be very cautious anytime I talk in this area to be aware of what I don't know and what I don't know that I don't know. So I'm looking forward to the responses and hopefully further discussion to be able to flesh out some of these issues. I have had a fair amount of time, obviously, in rooms with very smart people thinking about thresholds and the broader aspects of health economics, and also thinking about the ethics and how values and other aspects of how we envision this entire enterprise filter through every single step in the way that the methods are designed, the way that decision makers understand how this information should or shouldn't feed into decisions, etc. So, and again, I'm not going to even touch or try to touch on all the different ethical dimensions of cost effectiveness. They obviously permeate everything around the quality, the basic utilitarian structure and paradigm within which the quality is summed and applied within the analyses. So I'm not going to touch on those. I'm really, again, going to try to focus on the ones that at least I think are particularly relevant for thresholds. So let me just launch in here. So first, the outline of what I'm going to try to do is broken up into about 4 different areas. First, I'm going to talk about whether there are distinctive ethical issues related to having a cost-effectiveness threshold for the U.S. Then, whether there should be one threshold or many. Are there special cases? I'm going to then talk about some of the ethical aspects that filter through in our thinking about the relative, again, advantages and disadvantages or applications of results based on societal perspectives versus healthcare perspectives. And then I will, at the end, try to come back to talk a lot about what was at the very beginning of these lectures when people were saying, well, it all depends. What is ICER's role? What is the healthcare system and the decision-making framework into which this information is going to fit? And that should have a large role in our thinking about thresholds. So I will try to return to that briefly, but again, emphasize more of the ethical aspects of that at the tail end. All right, so first, just to make sure we're clear, there are lots of ethical dimensions of deciding which threshold to have, but I think there are incredibly important ethical dimensions of having no threshold in a health system, whether it's the US or elsewhere. So first off, without a threshold, I think we lose health and income and well-being through the misallocation of, in every system, what are ultimately pooled and limited resources, both for healthcare and all our other social goods. Not being upfront with even trying to have a threshold, to my mind, is a sloppy way that leads to bad outcomes. And now there can always be unintended consequences, but I think it's a mistake to think that any structure in which there's no attempt to have a threshold doesn't convey its own set of ethical disadvantages. So not having a threshold also has specific equity concerns, because without a threshold, I think there's a much greater risk that we will, in a sense, continue to enhance inequality in both health and income through, again, not having clear or transparent thresholds and therefore variation in care standards across insurers that are just not transparent to people. Does Medicaid have a different standard of care, a different threshold? Does the VA? Do different private insurers? Does Medicare? Without a clear statement of what a threshold is or isn't for these different systems, I think we do people a disservice, and we can, in some cases, really hardwire greater inequality. That lack of transparency is also an important feature in the fact that without transparency, we can't help citizens vote in ways that can convey their preferences through their elected representatives into the decisions that are made about the level and types of healthcare spending. And that, again, I think really does add to inequality in the U.S. Whether you want to call it an ethical or a political concern, I framed it political here because what I see is that this lack of transparency in decision making, it leads to an overall structure in which people feel like the only way to win is to beat the other guy. Because everyone knows, whether they're willing to say it or not, that there's limited resources. And if we don't have a clear threshold and a clear process for making decisions, then we get greed. I want mine, and if I get mine, you won't get yours. We get a cynical approach to how decisions are made, and a very divisive atmosphere in which decisions, hard decisions, that every mature health system has to make, they will always be contentious, but the whole goal of thresholds and a broader decision-making structure is to manage that in a way that can actually enhance solidarity, because there will be people who feel that they don't get everything they want. We all know that that has to be the case. So anyway, without thresholds, I think we enhance the divisiveness in our society. Okay, so now we're going to talk about ethical dimensions of different ways. And a lot of this was enhanced for me by the discussion of the last webinars, which I thought were really superlative. So my take on the ethical dimensions of the willingness to pay approaches, and some of this is a summary of things that already came up, was that largely on the equity side, willingness to pay forces us to answer the question, whose willingness to pay? Given that that is highly variable with income, a lot of the approaches in some ways may assume that, for instance, that the background labor markets are fair. And this was something that I was learning through the webinar, so I'd be interested in hearing further discussion from Pat, Carl, or others. But it seemed like the value of a statistical life in particular seemed to have a background assumption as people were answering these questions that the way that people do or don't take certain jobs and their relative revenue or incomes, I should say, in some ways has to assume that it's fair when often we know that it's not. Carl did a great job, I thought, of walking through the idea that if we pick an average willingness to pay or a higher end Blue Cross Blue Shield, I think was the way he phrased it. I'm not sure Blue Cross Blue Shield people would always feel that way, but if we're viewing it that way, whatever, the people with lower incomes may be forced in a way, if they're paying into that system, to pay too much relative to their own willingness to pay, their own opportunity cost, if you will, in order to satisfy the willingness to pay for the rich who already have enough resources to pay for the basic necessities and are therefore more likely to have a higher willingness to pay. If we do, that's the individual level. At the societal level, this can lead to our broader societal resources being drawn into health spending from other areas that, again, may be more important to people with lower incomes. So I just gave one example, public education, where we know that at the state level, a lot of public education funding has been cut, and in some ways people say that is because they've had to fund higher healthcare costs at the state level. So is that really reflective of the willingness to pay at the broader societal level of everybody, more for the rich than the poor? I think that's a very important ethical dimension. And we heard, as we were discussing opportunity costs of higher premiums, that basically, if you will, the willingness to pay, if we have higher premiums based on an average willingness to pay, that people with lower incomes may well be forced out of the insurance market entirely. All right. Nobody gets off scot-free here. So what are the ethical dimensions or concerns about opportunity cost approaches? I hope you feel like I'm giving equal balance to the two of them, but the main one that occurred to me was obviously raised again in the discussion that Anirban and others brought up, which was we start from a point of looking at the trade-offs at the margin, but do we know that the current budget itself is fair? Is it normative? So as I thought about it, in high-income countries where we do have mixed public and private systems, there's always a tension. Does the budget for the publicly funded side of it provide enough health care to really assure the equality of opportunity that is at the core of a lot of theories of ethics and equity? We're not necessarily talking about equality of outcomes, but at least in the United States context, we often talk of equality of opportunity. And even here, we need to make sure that, if it's an opportunity cost at the current Medicaid funding level, do we know that that's a normatively high enough budget to make sure that we're providing what we consider to be an equitable amount of health care to people in Medicaid? Easily identified are the equity concerns in lower and middle income countries, where we already saw that in some ways the threshold can be so low that obviously it is descriptive, and in a way it's normative in the short term, but should it really be considered a call to action instead of a long-term normative finding? And how do we identify when that spending does reach a level at which we would consider the opportunity cost at the margin to be equitable and normative? All right, I'm going to try to move very quickly because I really want to hear the comments, and given that this is the last webinar, we may easily fall back into reflections on some of the prior topics. This is a big one to me, as we as a health technology assessment organization put out our information. We recognize that the academic community has always called for the societal perspective to be part of what decision makers see when they are making their decisions. We have always included it as a sensitivity analysis, and we do have methods ourselves that create a dual base case in certain circumstances. But when I think about the ethical aspects of this, I find that the discussion around it is actually very interesting because people often see only one side of it. So what are the ethical factors in favor of using the societal perspective for the U.S. context? Well, one is that if you do societal perspectives and include the broader aspects, that the thresholds that you use may therefore reflect the effects of healthcare outside the health system. And many people feel that that's not only proper or appropriate, but I guess in those words, they also to some extent mean the ethically appropriate or right way to think about healthcare spending, that it has effects outside the healthcare system, and to ignore those is not fair, especially to treatments or to conditions in which the effects outside the system are very important. ICER looked at one topic in the past, year, which was treatment for a form of childhood blindness. And blindness, interestingly, has essentially zero health system costs. People have a few more accidents. There's some question about whether mental health expenses are a little bit higher. But essentially, people who are blind do not cost the healthcare system more. And so when you cure blindness, you have no healthcare system cost offsets. And so a cure for blindness is valued within the healthcare system much lower than the cure for a condition that might have the same quality changes, that might have the same utility change, but doesn't have any cost offset. So looking outside for blindness, you find that curing blindness does have beneficial effects financially on the disability system, on educational spending, and other areas. So, there's a good reason to think about the ethics of whether we're looking inside only or outside as well. So if we use the societal perspective, there's also an indirect effect that could push the private insurers who might be just focused on the health system to take into consideration some of these broader values. And if we don't take the societal perspective, we might, again, reinforce what could be viewed as a short-term and narrow view of value that does not represent patients' perspectives or families or society's perspectives, but only that of insurers. And then lastly, we may feel that doing a societal perspective, and here obviously I'm thinking as a component of that primarily the productivity aspects, maybe that does capture ethical values of the society in which we would want to prioritize care for younger and working individuals. I have heard very much that in lower and middle income countries, sometimes when they get right down to it, they really do want to prioritize their population that can provide resources for other families, for the community. This is a big part of their internal societal ethic. Okay, so that's in favor, if you will, of the societal perspective. The ethical aspects that would favor using the health system perspective, I think, are these. Well, again, whether they're ethical or practical. One, though, is that private insurers, and maybe even Medicaid and Medicare, they hold budgets for healthcare. That's their job. And maybe society is providing or should provide other budgets to support desired outcomes outside the health system. So maybe it's not, a private insurer's job to help support the educational system by providing health care that somehow has an indirect benefit on the costs of special ed for patients with a condition. You can argue that both ways, but some people feel that there is a system that provides for health care and there's a system that provides for other things, and it's not fair to put all the burden, if you will, on the health care system to pay for these things. The second one is perhaps more central, certainly, to our approach, in which we have decided that the healthcare system, from an ethical perspective, is our preference, as our base case. And we feel that including productivity as the base case really likely does, I put may here, but we think it does overstate or even misrepresent our ethical values. And the easiest way to see this is to realize that if you include productivity, you automatically would disfavor treatments for conditions of people over the age of 65. And the broader you make the societal perspective, if you include taxes and again, social security system and everything else, we already know that every human being in the United States ends up living their life and adding to the country's deficit. They certainly do from the age of 65 on. So do we really want to instantiate that as our view and say that a treatment, and we know migraine, when we looked at migraine, the societal impact, the societal perspective was very strongly influenced by the productivity effects. And that's important for people to realize and to discuss. But should it be the base case when we're going to compare the next topic, a cancer treatment or a treatment for something, visual aspects, anything that really strikes at the elderly and may not have any impact on productivity? All right, so the last bullet here says that if opportunity cost, and this is if you are in the camp of viewing opportunity cost as your preferred justification, I think one reason to use the health system perspective as your base case is that it's just harder to find data that you can use to set a threshold that does include costs and effects outside the healthcare system. I think this is open to dispute. I think some people would view that Dave Van Ness's work may capture some of our kind of feelings about, if you will, costs and effects outside the healthcare system, because people are making trade-offs about those when they're making decisions about whether to drop their coverage as the premium goes up. But I still think it creates some reason, if you favor opportunity cost conceptually, that the healthcare system perspective would be your base case. All right, I'm going to go ridiculously quickly through one slide, each bullet of which is usually a separate topic in an ethics course in some ways. But the basic idea are these. Do we have different thresholds or different, for different segments of the population? In some sense, health economists often following the logic in a US type market, you would say we should have a different threshold for health plan A, health plan B, and health plan C, and they should market themselves this way. If Mark Pauly is on the line, he will remember saying this probably, 50 years ago, Mark, if you're there. If not, we all remember his saying this basic idea that transparency counts, and the reality of the world should be that we have the ability to pick different health plans in which we can make our own willingness to pay decisions and have that clearly identified in the health insurance that we buy. But this has an ethical perspective, right? Some people say, well, that's maybe that's conceptually great, but do we as a society, no matter how we're funding it, through a public system or a private system, we can all look at each other and say in conversation, we have multiple tiers in our healthcare system. We all know that people with Blue Cross Blue Shield get quote unquote better access and quote unquote better care than people with lower, kind of funded insurance plans like Medicaid, maybe the VA. But do we really want to say that that's the way we want to kind of drive ethically? Do we want to try to create one standard of care and pay for it in different ways, or say, no, we have different standards of care, and that's just the way that it is? So there are ethical aspects of this. Another aspect of special cases that is brought up sometimes, certainly to HTA organizations, is, now look, past decisions, you can go back in history. Last year, 10 years ago, we've always paid more for cancer treatments, given the relative benefit that patients receive in life years gained or what have you. And so that is, in a sense, the right thing. That reflects our values. And some people translate this basic insight into the idea that we should do efficiency frontiers as our approach to thresholds. That we should have a different threshold for cancer, to blindness, to cardiovascular problems based on the efficiency frontier. Ethicists view this in the light of thinking of the old ethical chestnut, which is does is mean ought? Is what we see a reflection of our ethical norms? And so here again, most people that I'm familiar with in health economics and in ethics, although they struggle with this to a certain extent, most people believe that true fairness would require us to back up and to say that past decisions do not necessarily reflect the approach that we would want to take going forward if we are trying to take a broad view of the health system and make sure that health gained by some patients do not lead to greater health lost by others. Orphan conditions, we will be arguing about this forever. Is there something about rarity that we value and that therefore we would wish to give a different threshold to? ICER is one of the HTA organizations that has decided yes and no. So we have not just all orphan conditions, but ultra rare. We actually pin our ethical perspective on this, not on the fact that there is or isn't a social value for rarity, but that at a certain small number of patients, there may be return on investment issues for an innovation that would require a higher threshold to gain enough capital back to keep the pump flowing. But ethicists will still argue about this, both pro and con. And we all know that different systems, HTA systems at least, have tried to grapple with social values related to things that are variously called end of life, or severity, or lifetime burden of illness, or need. And again, it's very interesting to see how this plays out in different countries and why in some ways. But they all try to get to that basic idea that, you know, the quality itself, given that it's a utilitarian measure, is blind to whether qualities are gained at different ends of severity and by different patients over time, and maybe that there are qualities that are valued more. And that's where we get some of these ideas. So some of them are implemented through quantified kind of weightings of the quality. It's fascinating to watch how, for instance, the Dutch and the Norwegians take, in some ways, the same issue around severity. They call it slightly different things. One country picks the absolute quality shortfall as a way to structure different cost-effectiveness thresholds, and the Dutch use proportional quality shortfall to do the same kind of thing, a stepwise approach. So these are ways that ethicists have obviously viewed that there are social values and that maybe we should try to create different thresholds. But every time you do, you're also creating a broader question of whether we should be doing this quantitatively or qualitatively. And this is a huge question for ethics and for the use of thresholds, because that's one reason that we use a range, and that actually NICE and others use a range, is because you can say, well, we're qualitatively trying to capture multiple things, uncertainty, some of these social values, other factors, maybe budget impact, and that these can all be weighed qualitatively in a deliberative process in a way that's better than trying to do one-off quantified weightings of each individual one. Now, this is leading me to a discussion of MCDA, which I will get to. But first, let me just back up and now pitch a little bit about what ICER does in this regard. So here is our conceptual picture of our value assessment framework. I'm not going to take a lot of time to run through it, but you can see it has a goal at the top. Carl mentioned it in his webinar. And it is this idea that we have a blended goal of having fair prices linked to fair access, not just linked, but in a sense, creating the structure in which we should demand fair access and to be able to achieve future innovation. We strongly believe that decision makers in the U.S. do think about or need to think about two different elements in arriving at that goal. One we have termed long-term value for money, and the other is short-term affordability. So within long-term affordability, this is where I'm getting to some of these issues, you'll see the four different conceptual categories that we consider. And in the U.S. context, we have felt it's important to keep comparative clinical effectiveness, if you will, as a separately viewed, discussed, and voted upon category. But we have incremental cost effectiveness, and what we label other benefits or disadvantages and contextual considerations are where we have tried to capture some of these other ethical issues to some extent. And we have actually 2 years ago, when we went through our last value assessment update, we proposed a stepwise set of different cost effectiveness thresholds that would be based on a weighting of these contextual considerations and other benefits or disadvantages. Interestingly, that had been spurred in some ways by our own thinking, but also strongly supported by initial comments from multiple stakeholders in the U.S. healthcare system. Patient groups, manufacturers in the lead, were calling for the quantification and addition of these factors to our considerations, and in some ways weighting or changing the threshold. When we came back to them and said, we will propose this, and we will take our current cost effectiveness range and slice it up into different areas in which these factors will be, in a sense, dispositive, people lost their enthusiasm for this idea, because instead of it being just adding value at the top end of any range, when viewed as a way to discriminate or distinguish within it, it started to create winners and losers, and people were afraid that the unintended consequences might make them a loser. And if they could always claim the upper end of the range, of a threshold range anyway, why would they want a risk of being pegged lower? So that was an interesting kind of social experiment, if you will, in discussing ways to bring some of the ethical aspects that I've discussed into different types of thresholds. So I've talked a little bit already about integrating these thresholds, and again, whether it's going to be qualitative or quantitative. I'm a big fan of the idea of multi-criteria decision analysis. When I first read about that, I was thrilled. I thought this is the next step in the evolution of transparent, explicit decision making. You've got your threshold, you've got your other factors, you weigh them, you bring it forward, you do it in public. It might not be pretty the first time you try it, but you keep moving forward and you get it done, and it adds greater a greater calibration of decisions over time. I still have a hope that might work out someday, but I can say that we pilot tested two approaches to multi-criteria decision analysis about 7 years ago, and it was a huge failure. And I think, again, it can be, I'll take full responsibility for it, because I don't think we prepared our panels adequately for the exercise, but we tried to give them discrete elements of decision making and to have them weigh them, and they were utterly unable. And it's just really interesting to hear people describe how they make decisions. They kept saying, well, I looked at A first, but A depends upon how B influences C, and then it folds back into E. And uncertainty was often part of that chain. And you couldn't get them to describe how they factored all these different pieces in a way that remotely felt transparent and remotely felt good. And if I'd only taken a picture of their body language and their faces as they tried to do this exercise, I think you'd understand why we decided not to do it again. And we've kept our elements essentially qualitative in the time since then. Budget impact is often considered another contextual consideration, and whether it's woven in quantitatively or qualitatively, I just figured I shouldn't leave it out, because it's always should be a part, I think, of how cost effectiveness thresholds are discussed more explicitly by decision makers. And as I mentioned, to me, the key question for threshold artists is, are you using any of these factors to bump your threshold up, to bump your threshold down, to move within a range? And so to me, that's where opportunity cost becomes a key factor. Because if you have a justification for your range and you start adding new things, somehow it has to be on the same playing field. You can't just say that there's more value. Now, I could be wrong. It could be that the things that you're adding are parts of the willingness to pay that for some reason haven't been factored into an opportunity cost approach or what have you. But to me, this is still, it's a very interesting question that I think people need to consider to wrestle with. All right, just one last slide or two. First of all, people often say, again, so what's icers' role and how should that influence how we're thinking about thresholds? So we do all this work, comparative clinical effectiveness. We have a section in our report on potential other benefits, contextual considerations. We have public deliberation with all kinds of input and testimony. We have votes. At the end of the day, what we're known for most, certainly by the media and by payers to this day, are our pricing recommendations, structured to the range that we have so far identified as 100 to 150,000 per quality. And just to make sure for the people who are on future perhaps viewing this webinar, our application of that range, and here you're seeing the application of the upper end of the range, the 150,000 per quality threshold, in the U.S. context has led to approximately two-thirds to three-fourths of the launch price as being viewed as too high. But that means that even for some very highly priced drugs, we have found that they are not. Their launch price in the U.S. market is not above the 150,000 per quality threshold. Here are just a few examples. Luxturna is a gene therapy that I mentioned for childhood blindness. We did say that that one, our recommendation was the price was about 50% too high. But other very expensive treatments are either in line with that cost effectiveness or obviously they can be cost saving. I'll skip over to the other where, again, even for one condition, we had two treatments, one of which would require a very steep discount to meet a cost effectiveness threshold, the other none. The largest difference in that is one is a continuously chronically administered drug for the rest of the patient's life, and one is a one-time therapy. Some differences in effectiveness, but that's the biggest kind of difference in whether one is cost effective or the other. So our work is being used a lot to talk about fair pricing at launch. Other users are using it in ways somewhat similar. A couple important ones. Medicaid is using it in New York, where they have a relatively new law from 2017 that established a drug spending target for the state's Medicare program. And each year, if the spending is ahead of trend and will exceed that target, if you will, they are now formally allowed to identify drugs where they think they might be overspending for further evaluation of value. They take companies behind closed doors to negotiate, but if they cannot come to agreement on a lower price, and this is even lower than the Medicaid best price that they would get through the usual statutes, that can trigger a public process in which they have a meeting of their Drug Utilization Review Board to publicly decide what the target price should be that Medicaid should try to negotiate to for a supplemental rebate. So far, this has happened last year for one drug, Orkambi, which is a drug for cystic fibrosis. And again, the way our thresholds were used, I wanted to show you. So we presented to this public meeting of the New York Drug Utilization Review Board our base case results. This is Orkambi versus best supportive care. The cost per life year gained at the current price, $1.3 million. Cost per quality gained, around $900,000. We did a cost to consequences, the cost per single exacerbation, $326,000. So we then showed them threshold results. We gave them 50 to 500. This is our standard approach currently for ultra-rare conditions. We have stated in our methods that we do know historically that decision makers often view contextual considerations and other potential benefits more strongly or differently for ultra-rare conditions. So we give a broader threshold range, but our own value-based price recommendation remains at 100 to 150,000 per quality. I said almost exactly those words in a public meeting to the New York Drug Utilization Review Board. Their independent decision was to use this threshold as the target price for the Medicaid system in New York. They said that because it was an ultra-rare condition, this would be their threshold. Their judgment was that if it had not been, they would have used the 100,000 per quality choice. Now, you can say, who was leading whom? What had they read before? I can't quote you. They were, obviously I know what I said, and they had their own discussion around this. So, but it's an interesting, if you want to take revealed preferences or revealed decisions for preferences, this is one public process so far in the United States at the state level that has identified this threshold for their decision making as an ultra rare condition. What they got out of that was some backup publicly, some articles written saying not that they picked the right cost effectiveness threshold. People didn't get into the weeds on that, but it triggered an important, I think, public discussion, and the idea that drug pricing should be linked to the incremental benefits for patients was a strong message that was picked up by different commentators, not just Peter Bach, but others. Okay, real quickly. So other states are now following, interestingly, the New York model. They obviously view that as one of the experiments, along with drug reimportation and other ways to help control costs, perhaps. Massachusetts just passed, and the governor signed, I think within the past 48 hours, a bill that creates a very similar process to that of New York, has a different committee that the work goes to ultimately, but its goal is to lead to a process for identifying fair prices for the state Medicaid program to negotiate with manufacturers. The VA uses our assessments to negotiate prices, but does not have a standard cost-effectiveness threshold-based formulary or anything like that, but it helps them, they feel, back up their own sense of appropriate pricing and value. Similarly, private payers and PBMs have largely used our work in what I would call ad hoc. When they have a report, they look at it and it helps inform both their understanding of the clinical information, but also they use our recommended prices as part of their discussion with innovators around pricing. One quick mention of a structural application, which is different, is a new health benefit design that was developed by CVS for its employees and for a small number of other self-insured employers. This is the first case that a private PBM has used our work to say that if the best negotiated price for a drug, and it has to be a non-breakthrough drug, which implies that it should be another alternative, but if the negotiated price does not fall below $100,000 per quality, according to our report, CVS has the option of declaring it a non-covered benefit. So there are lots of things we could talk about in terms of this particular application, but in terms of thresholds, it's important. I should mention that this was developed without direct input from ICER, and when I spoke to CVS afterwards, I said, 100,000, why did you pick one line in the sand? They said, well, we actually thought about it a lot ourselves. We think our range is 50 to 100. But to administer it as a health benefit design, you can't leave it as this gray zone. You have to have a certain cut point. And it doesn't mean that it has to be non-covered, but it allows you to make the decision based on that. So I thought, well, that was great. You should have messaged that. It would have helped people understand a little bit more around the thinking of how you're integrating a range and a threshold idea into your decisions. So, but what we got was a pretty stark vision of a single threshold applied as an off-on switch, which obviously raises lots of people's concerns. And lastly, there is current discussion as Medicare negotiation becomes a hot and hotter public political topic. When people get down into the weeds, they often do discuss ways that Medicare would know what a fair price is to negotiate to. And obviously, having threshold recommended prices has been part of what many policymakers are talking about, either during direct negotiation or as part of a fallback arbitration process if negotiation fails. Okay, now my last slide. So, what is our goal, and how does that inform our selection of thresholds? I think we really are here to support all different payers in the U.S. context. And does that mean that we should have different thresholds for all payers? I'll jump to the point that I feel from an ethical perspective, our strongest argument is that until the public really does explicitly say we want a different standard of care for Medicaid than for Blue Cross Blue Shield, our job is to create a normative range of thresholds that should apply to all payers and all individuals in the United States. That may be crazy because I know it doesn't match the reality of the care that people do get through different access structures, But this is why there's a tension. Medicaid or other insurers might have much worse, quote unquote, access to providers. But if you look at their formularies, they're just as good or better than private insurers because there is almost a medical legal term, medical necessity, that is broadly viewed as the same across all different insurers. And until that changes, we have felt that ICER should have a common range for all decision makers in the U.S. Obviously open for discussion. Budget impact, since that's still part of the decision, can certainly be viewed differently by different payers, and there are very different budget impact considerations. But as far as a long-term value for money, we have felt that that should be viewed using the same threshold range. But what is our environment? A lot of people say a lot of what you should think about with your threshold is whether you're in a system in which it's a cost-increasing search for high-value opportunities where we can spend more money and get better health. Or are we in a system where we're kind of just balancing the resources that we've got for the most effective use of those? Or are we about trying to reduce the costs? Is this an enterprise that's meant to reduce the cost of drugs or other services in the U.S. healthcare system? And I will say that there are lots of ways you can think about this. When you look at when we listen, we ICER, listen to policymakers at the state level, in the VA and Medicaid, and yes, in the private insurance market, what we hear are people saying that we are at the cap. We are at the cap in our societal spending for healthcare, at which we are already probably trading off more than we would want to if we could have it back again, but that we certainly don't want to grow faster in our healthcare expenses than our economy is growing at this point and draw further from our other societal spending into healthcare. Now, that's at the societal level. Again, if you talk to individual employers, it depends, right? There are some employers who are still trying to figure out how to create richer benefit packages to attract the youngest, best, tech workers. A lot of purchasers aren't. A lot of plan sponsors are saying, I do need to cut costs because I haven't been able to give these guys a raise in years, or I've had to lay off people to keep the health benefits. So there's a huge spectrum, but it doesn't feel to us that we're in a cost increasing search, at least for higher spending. And at a societal level, I don't know if this is big enough for you to see very well, but there are lots of different graphs you can show. This is one of my favorites. It shows the United States going back to the 1970s. And the curve here is life expectancy on the vertical axis and health expenditure on the horizontal axis. And for a while, we were in that nice steep part of the curve with everybody else. And then around 1980, I'm not really sure what happened in 1980, to be honest with you, but suddenly we hit this different trajectory where health expenditures kept growing, but the health gains stopped growing. Now, this is life expectancy, so you could say you're not capturing quality of life gains, and if you looked at that, the curves would look much more similar. I can't disabuse you of that argument, but you can see here that there is a stark difference in the way that our spending is relating to increased life expectancy, and the flatter the curve, the less, I guess you could say, value we're getting for increased spending. So this is one graph. I chose not to inflict another one on you, but it's another one of my favorites in which it is the state of Massachusetts. Its state spending for 10 years, and it breaks it down by health spending on its employees and retirees and Medicaid, public infrastructure, police, education, public health. I forget the other components. There are about 8, I think, line items in the state budget. Over 10 years, health spending on an inflation-adjusted basis rose 60%. And the question is, where did that money come from? Did taxes increase in Massachusetts over 10 years? Actually, they didn't. Under the administration's, taxes did not increase. Every penny of that health spending came from cuts in other lines of the state's budget. And you see, again, the question of whether we are trying to cut health expenses or maintain it. To me, the answer is that we are in a cost balancing search right now for the most effective use of existing resources. You could make an argument that we should be reducing costs in the healthcare system, and I would not dissociate myself from those. But I feel like ICER's conceptual approach to thinking about thresholds right now is that we are trying to help our society make the best use of its existing resources. If it wants to make more resources available for health, we'll help, hopefully, cost effectiveness decide how to make best use of that. But right now, it feels like we are in a sense, a quasi-equilibrium state. So in that case, I was fascinated earlier in these webinars that Chuck Phelps and Dave Van Ness came up with almost the same bloody number, to borrow Carl's phrasing. And I'm not a health economist, but through some nice tutorials from Carl, basically, if our willingness to pay, if you will, if our consumption curve, if I'm using the right term, but basically if our way of linking well-being and health expenditure gets us the same numbers we get when we look at the opportunity cost of people who lose health and lose insurance by where we are with premium increases. If we're getting the same threshold, even in the same remote ballpark, that means that K is approximating V, and that may suggest that it's another reason of thinking maybe we are at equilibrium at around $100,000 per QALY, not too far off, certainly from one part of our range. So I'm going to conclude by saying this has been a fascinating series of discussions, and I'm looking forward to Patricia's and Carl's comments. But no matter what threshold or range we at icers select or others, we all have a responsibility to really make sure that we educate the potential users. In the U.S., where there's not one governmental agency that's sophisticated in using thresholds and making decisions, I think it is incumbent upon us at ICER, and hopefully you as well as part of this broader community, to help make sure that end users do understand how we should be embedding CEA in broader decision-making frameworks that are sensitive to many factors, but especially the ethical dimensions that we've talked about today and that are going to be part of any priority setting process, whether it's in the US or elsewhere. So thank you, and with that, let me hand it back over to Rick to moderate the responses.
Thanks, Steve. As we mentioned, we've invited a couple of respondents, first of whom is Patricia Danzen. Patricia, do we have you on the line?
Rick, I think we should have Carl go first, because I think I need to get.
So we're going to do Patricia first, so we can go ahead. Yep. Can we do Patricia first?
She dropped off. She was having Wi-Fi issues.
Oh, she did. Okay,
so
Carl,
I'm
you're
send
first.
her the right information.
All right, Carl.
Okay. Then turn it over to Carl.
Okay, cool. Listen, let's be really clear. Things like incremental cost effectiveness ratios are a really kind of useful, helpful summary, and have been in the past, of what are inevitably quite complex analyses, which can never hope to capture all attributes of important aspects of health or social value. Nobody would ever claim that they ever could, but they're a decent, useful, accountable starting point for important, accountable deliberations. The same goes for the notion of a threshold. It's simply a summary of how bodies, organisations that make recommendations tend to judge things in terms of whether it's good value, not good value, and also what scale of rebate we need to regard it as good value. Now, on my desk in my office, I have a swear jar, okay? And for I include myself, for myself and all my colleagues, if you use the word threshold, not as a proper noun, in speech, in PowerPoint deck, or in a published paper, there is a menu of fines. And if you use the acronym CET, cost effectiveness threshold, all the fines get doubled. And the reason why is because by just talking about threshold, we fail to give clarity, we fail to educate, and we fail to move the debate forward. We need clarity. You do not pay for your health care at points of need, others do. And they pay for it in different ways. In the UK, we have it easy. It's pretty simple. Other people pay for it in only one way, because you know what? All our healthcare is free at the point of delivery. You don't pay a penny. Okay, $10 for a prescription, but hey, that's not a lot, although actually it's a struggle for some people. 80% of our prescriptions are free anyway because of people's are exempt. So in the UK, we pay for everything in the form of other people's health. It's a bit more complicated in the US, outside of your single payer systems. In your private insurance systems, people pay in a number of ways. We have beneficiaries. They get some health benefit, but they have to pay some consumption cost. The federal government also pays some of that cost, which is taken from other US taxpayers. But we've also got another set of people. We've got people who are not the beneficiaries. Some of them are going to drop their coverage, and they're going to pay with their health. Some people are going to stick with a plan, but they're going to pay more consumption because they're going to have to struggle to find that premium increase, or they're going to have to struggle to find the increased copay on some other completely unrelated healthcare issue. They're also going to pay a bit of help because the plan's going to try and reduce costs and they're going to try and reduce benefits and make it more difficult for you to get access to effective care. So that's at the heart of this, and I think just setting that out as it's a K and it's a V, just set out what are the effects on the beneficiaries and everybody else. So the idea that this is a full-blown societal perspective where we have tried to value or identify all things that matter to society and figured out how to value them versus this very narrow healthcare system perspective, I think is a false dichotomy. I think the most appropriate thing will be to say, look, our perspective is health and the directly related consumption effects of this decision that's in front of us. Because you know what? Impoverishing people by saying yes at this price through co-pays or not dropping your coverage and sticking with it, that is bad. That is bad. It has a bad, well, listen, I'm going to stand it like Trump. It's bad. Okay. It's just bad. Okay, right. I think I've done that. I've done it really quick. Okay. Does telling the truth mean that we're saying the status quo is okay? Absolutely not. Absolutely not. I disagree with Anna Van. I'll be seeing her on Monday. We'll have a right good set to over a beer in my local pub. Absolutely not. Telling the truth does not mean you think it's okay. Telling the truth is telling the truth and asking people, are you happy with this? Is this what you wanted? Is this what you expected to see? And if not, it's a call to action. Do something about it as a citizen, as a patient, and as a consumer. So health effects matter, gains and losses. Beneficiaries, enrollees, and taxpayers matter. Let's use the analysis to set that out. ICE is not the decision maker. That's true. But ICE has got a duty to inform decision makers about what the health effects are going to be and what the costs are going to be. It also has a duty to inform the actual decision makers who will be putting their careers and jobs on the line and their plans on the line to inform them about what an appropriate K and a V might look like for them. So ICER has a duty. If ICER walks away from this, they abdicate a key responsibility, and all the most sophisticated analysis in what the health effects and costs might be ain't worth shit unless you help inform them about how to judge these key questions. Now, I think what that means is ICER should have a range for K, a range for B, across the kind of single payer and private health plans that are out there. What value should ICER take as its central estimate? Well, it shouldn't be the Blue Cross Blue Shield high end of that range. Because if you do that, you are going to force the Jonestown Company and those construction workers down in the valley in West Virginia, half of them addicted to prescription opioids, to pay in their health and with their consumption for that Blue Cross Blue Shield plan, and all the guys and girls wearing Armani but wearing Ralph Lauren on a dress down Friday. Now that cannot be right. As for future innovation, absolutely. But future affordable innovation, you know what? We get innovation from lots of different ways, right? The best film I saw this month was Apollo 11. I knew the ending and I wept halfway through it. And amazing, incredible. The intellectual effort, the courage, unbelievable. And you know what? But you know what? There's lots of different innovations and we don't know where they're going to lead. And society makes very different choices and ones that might not make total sense. When JFK said we're going to the moon, I mean, that was crazy, man. Do I think there was enough payoff from that? Actually, no, I don't. But, okay, where am I going with this? Okay, let me try and spit it out. As a society, we make lots of different choices. There's lots of kinds of innovation, and we should focus on those that society believes will bring long-term social benefits. As a planet, we face a real challenge, and it ain't just healthcare. It's about actually the environment and making things sustainable. So, key thing, Gil Scott Heron. Listen, this is my last word, and I've got to finish on Gil Scott Heron. I can't pay no doctor bill while White is on the moon. 10 years from now, I'll be paying still, but White is on the moon. Do I think we should have cancelled Apollo 11? No. I think we should have made sure we could do both. That he could pay his medical bill for his sister now, and that's where we need to get to.
All right, thank you, Carl. I think we have Patricia back on the line. I hope we do. Patricia, are you there?
Yes, I'm on the line, but I can't see my slides. So if someone could do those for me, I'd appreciate it.
Sure, I've got it for you, Patricia.
Okay, and I did lose connections sort of in the middle of Steve's presentation. So if what I say is not relevant, I apologize. But based on the slides that I had seen, I wanted to make a couple of points related to the discussion of ethical dimensions, which, by the way, the whole presentation was excellent, and these are really additional thoughts. On the ethical dimensions of not using an ICER in the US, I think more emphasis needs to be given to the fact that if we don't use an ICER, basically we're giving up on using the most efficient constraint on prices. I think you tended to focus on the use of ICERs to determine what is covered and what's not covered, but that coverage decision, if used consistently by payers, creates incentives for producers to adopt prices that will be commensurate with the thresholds. And so by not using a threshold, we've basically enabled prices to go up in a manner that's been totally unconstrained. And unfortunately, even our current debate on ways of constraining prices is not considering the use of ICERs, which would be the most efficient approach. One other point on your ethical dimensions slide, you commented that the value of a statistical life analysis seems to presuppose efficient labor markets. I would just re-emphasize a point Chuck Phelps made yesterday, that value of a statistical life analysis really is based on a framework for estimating willingness to accept risk in which there is no budget constraint. So it is truly not relevant for choosing a budget and choosing a threshold for healthcare in which we very much are facing budget constraints on how much we have to spend on all goods and services, including health. On the ethical dimensions, next slide, please. Willingness to pay approaches, possibly being inequitable. I would submit that in a broad sense, they need not be, that for sure, because there is variation in willingness to pay, that justifies using different ICERs for different plans in the US. But that the willingness to pay of the poor should include not only their own willingness to pay for themselves, but also the altruistic willingness to pay of taxpayers on their behalf. And we do not do this well in the US yet, but certainly it's exemplified by our taxpayer support for Medicaid, Medicare, the ACA subsidies, etc. And so when we're thinking of willingness to pay for those too poor to pay for themselves, we should be including the altruistic willingness to pay of others. And more generally, I think the way to think about the US system being a pluralistic system is that we can have an approach to equity that assures a basic floor, a basic decent healthcare system for everybody, but leaves wealthier people free to buy more if they want to. This sort of approach is used in many countries, and it does mean that there can be variation in the ICERs being used. But important point, when we're looking at the willingness to pay of wealthier people to pay for themselves, we should be netting out and hopefully eliminating the tax subsidy to employer contributions, which is a massive regressive subsidy that distorts the willingness to pay of wealthier people for healthcare. That also applies when we look at trying to measure opportunity cost as a source of thresholds using current budgets. That too is distorted massively by the tax subsidy to employer contributions to health insurance. More generally, I think if we look at past decisions and to what extent do they reflect what we are willing to pay versus what we should be willing to pay, I do think that we have to be realistic in accepting that certainly in the US, they also reflect, any collective decision reflects the influence of what uncharitably would be called lobbying, more charitably might be called stakeholder influence. But certainly there is a whole theory in economics of how concentrated interests influence political decision making more than diffuse interests, and that is certainly writ large in our healthcare decision making. Looking at how we might implement different icers across plans in the US, it's certainly, next slide please, it's certainly theoretically desirable, but I think the implementation is more difficult than most people have acknowledged so far. And I think it probably will require the use of confidential rebates, which flies in the face of your desire, Steve, and I think of many people, for more transparency. And the point is this: if we've got Plan A that's using 100,000 per quality and Plan B using 150,000 per quality, say, Plan B would have more drugs covered, but in principle would be willing to pay higher prices. But if they can see the prices that are being given to Plan A, which is only using the 100,000 per quality threshold, then Plan B would certainly not voluntarily pay those higher prices. And so to implement differential pricing across plans may require allowing producers to set the list prices based on one of the higher willingness to pay thresholds, but then reaching the lower willingness to pay thresholds using confidential rebates. That does enable differential pricing to happen. At the moment, that is the way differential pricing is working in the US. And admittedly, we're probably doing a poor job at making sure that those rebates ultimately get passed through to those who pay, the consumers, the taxpayers, etc. And so that is an issue to be addressed. But I think that the idea that we can implement different ICER thresholds and simply have different list prices for different health plans is a non-starter, because nobody's going to be willing to pay a higher price if they can see that somebody else is getting a lower price. Finally, next slide, please, on the societal versus health system perspective. I do feel it's important to emphasize that if we're trying to measure the non-health benefits of healthcare, then we do need to be consistent in applying that to the other ways we might spend our money. And a good example of that is education, where we get not only education and higher wages, but also improved life expectancy. More educated people have higher life expectancy, as well as all sorts of other benefits. So trying to do this in a consistent way, I think, really does go beyond what we're able to do with our current data systems. But at least when we're trying to apply it to healthcare, we need to be mindful of that. I would question the presumption that was in your presentation, Steve, about society's ethical values related to prioritizing care for younger working individuals. And others may have commented on this. I think the preference for services for younger people is probably adequately reflected in the more life years that such treatments can potentially buy. And then focusing on working really ignores the extensive debate that I think has been resolved in recognizing the real social value of non-labor force participation that involves activities that have very socially productive outcomes, like caring for families, caring for other members of the family, etc. And so the idea of focusing on working, I think, is really not generally accepted, certainly by economists. Final point on that, I think if we do sort of emphasize trying to measure the workplace benefits of healthcare, we run the risk of cost-effectiveness analysis again being rejected as violating the Americans with Disabilities Act, which was the basis for rejecting the use of CEA way back a couple of decades ago. And I think hopefully we learn from that and can use a broader measure that would not lead to that perception that using cost-effective analysis has that built-in bias. So that's all my comments, and thanks for an excellent presentation.
Oh, Patricia, masterful. Thank you. I was so concerned when you were lost off the recording. I was hoping you would be able to find your way back. So thank you very much. And Carl, you too. Just very briefly, because we're already over time, but I think I'm going to respond mainly to Patricia's points. I think your point about the effect of thresholds to help constrain prices, to setting a clear target that happens upstream in the decision making around how prices happen and even which innovations are pursued, is exactly right and a very important piece of how we hope our work can be used. And without thresholds, you're right, you end up with a muddy kind of the prices are too damn high kind of argument, which really doesn't send a clear enough signal to innovators and investors around that. Your last point, I'll jump to quickly, which was I kind of set up that quote unquote preference for younger individuals as kind of a straw man, just because in some societies that may be the case, but here in the US in particular, it's one of the stronger reasons why we do not accept a traditional societal perspective with productivity woven in. Your point is that we could do a better job of probably valuing or weighing, if you will, the X market kind of benefits that we gain from homemaking and care of the family. But in general, it still leaves the elderly in particular as kind of disadvantaged in a societal perspective. So to us, that remains an important feature. Just one last question I'll ask real quickly of you, Patricia. When we at ICER end up wanting to frame our thresholds for decision makers in the US context who are not familiar with cost effectiveness, it has been raised as a question of why don't we say that the threshold, we're not even going to talk about a threshold, we're going to talk about whether we lose more health than we gain with this intervention. So you basically take opportunity cost, you don't talk about a cost per quality, but you say with this intervention we would gain 10 qualities, but because of the increased cost in the system we would lose 10.4 qualities or something like that. But at a lower price, we would get more health. What do you think about that way of describing a threshold to decision makers?
I think it makes good sense. It does still raise the question of, well, what is the threshold and how do you, as you make that, come up with the appropriate measure of what is given up? So it presumes you have a good measure of opportunity cost. Whereas I think that, some people would understand opportunity cost sort of intuitively much more easily, and other people might understand willingness to pay by looking at what we're willing to pay for saving a life here or a quality in other contexts, and examples of where we refuse to pay very high prices for a quality from other contexts, I think can be compelling in saying, well, we shouldn't be doing it here. And then the point being that, if we are inconsistent, then we're really giving up health and life years.
Right. So that's a great response, and I find the exact same experience, which is intuitively I like it with decision makers who are not cost effectiveness or health economists, because they can see health being weighed, and we want more health. And if we think we can really decide that we're going to lose more health because the cost has these unintended consequences, but then you will drive a real focus on your logic to get that opportunity cost. And so you have to be pretty strong with your rationale and with the data that would suggest that we know we're losing more health than we're going to get with this kind of intervention. Just politically, I'll make another quick comment. I'm running way over, but willingness to pay when discussed with policymakers in Washington, D.C., for instance, it's an interesting experience. Again, I don't try to teach cost effectiveness to those folks that often, but every once in a while when they want to know about the thresholds, if I talk about willingness to pay, it triggers this almost patriotic sense of we should be willing to pay anything. There's a psychological effect that I've witnessed with the term willingness to pay that I'm not sure economists recognize, and it's not helpful because it makes people feel bad if they say, why wouldn't, we're always willing to pay, because then they get into the identifiable patient problem where they're saying for that patient, for this condition, we are willing to pay a lot. And so I'm not suggesting that that's a reason to discard the term in health economics or to discard it even from a political perspective just because of the way people hear it. But I'm just reflecting on what I've experienced as an interesting reaction to that term.
Yeah, I totally understand that, and I think we need to push back against that sense that we are willing to pay anything. Demonstrably, we're not, and the sooner we get clear on that, the better.
Well, the sooner we get you to Capitol Hill, the better, Patricia. Let Carl have a real quick thing, and then I'm going to wrap us up.
Just a real quick thing. As long as we get the opportunity costs right, and I think I agree, I think it's very difficult on willingness to pay. It's very easy to communicate on the health opportunity costs, and I have to say in the UK, it's been a game changer in terms of the ease of communication, being able to go on live TV and debate patients who've been denied care. It's not an easy gig, but it's a possible gig, and I never turn down the opportunity to do it because that is my atonement for earning money of figuring out ways to deny care to people. That's how I've made my money throughout my career. So any journalist asks me to debate a patient or the father or mother of a patient, I say yes. I think willingness to pay is a little bit more difficult, but I do think there are better ways to do it, actually. I think there are ways to do it. You know, that trade-off, you know, hey, you need to pay your rent, yeah? You need to pay your electricity bill for the aircon, you know? These are important trades, but I just wanted to, just one thing. On this question of innovation, if we get the opportunity costs in terms of health and consumption right, innovation takes care of itself as long as we're willing to leave it to private capital. It will make sure that the kind of innovations we get are ultimately affordable rather than the current situation where we are incentivizing profoundly unaffordable innovations that are damaging the rest of the world. And I guess that's my attempt to explain why I wanted to talk about Apollo 11, right, which might not have made that much sense. But there's lots of different innovations that we could be investing in that could make a real difference to everybody insofar as we figure out how to make sure that we don't all suffer from climate change, as well as a variety of other things. And you know what? You know, India, and this is a trade on innovation. India had a soft landing on the moon 2 weeks ago. It cost £140 million. With the Cancer Drugs Fund in the UK, money directly taken from NHS care, we could have 3 soft landings on the moon. Now, I'm not saying I want to take that money away from the NHS for us to be sending soft landings to the moon, but what I am saying is let's just compare the scale of innovation of those 2 options. And that's what we need to have in mind when we're told you've got to continue paying more than you can afford because of future innovation. Well, hey, 140 million gets you to the moon.
I think we need Jens Gruger back to discuss this is a future topic of a webinar. So I just want to, again, Rick and I have been together in a way moderating these, but I'd like to just have a really brief last word in which I thank all of you for listening. I want to thank our visiting fellows and all the responders, Patricia, Dave Meltzer, Chuck Phelps, well, I'm going to forget folks, Chris McCabe, who else? Lou Garrison.
Anirban.
Yes, Lou, there you are. Anirban. Okay, shouldn't ever do something like that, like the Academy Awards. I need my list. But I've found this to be spectacularly helpful for ICER. I hope you've enjoyed it. I think we'll make it an annual tradition of our visiting fellows to participate in some kind of external process like this. Maybe others would want to help us plan it. But thank you again for everybody's participation. And these discussions will continue to have a real impact on the United States. ICER will put out its proposals for its updated value assessment framework on August 16th for public comment. That will be our first chance to translate some of our thinking into proposals for how we will further define and justify our use of thresholds as part of the broader package of our methods. So look to that. We'll look forward to your comments on that. And again, thanks to everybody who's participated.